You guys can clap, too. Celebrating a huge milestone. 2 months after proton therapy began here at the University of Kansas Cancer Center, one of the first patients rings the bell. Her story and the impact the new therapy is having in the metro. The Morning Medical Update starts now. Good morning. It's Friday, July the 15th. I'm Dr. Steven Stites, Chief Medical Officer here at the University of Kansas Health System, in for Jessica Lovell. We are in the Dolph Simons Jr. Family Broadcast Studio. Thanks for joining us here on Facebook, YouTube, and Twitter. It's been 2 months since cancer patients have been receiving hope in the form of a pencil-thin beam of proton therapy. And today, we'll hear from 2 non-cancer patients using this beam to treat their tumors as well. Our experts today are Dr. Ronald Chen, the chair of the Department of Radiation Oncology, Darren Kistler, Senior Director, Radiation Services at the University of Kansas Cancer Center, and Sarah Solomon, Proton Nurse Navigator. And we'll hear their point of view coming up. Plus, Dr. Dana Hawkinson will join us with the latest COVID-19 numbers and headlines. And starting tomorrow, 3 numbers you can call if you are feeling suicidal. This show would not be possible without your questions. We love answering each and every one of them, so make sure to get your questions into us on YouTube, Facebook, Twitter, and the Medical News Network. You'll find those links right here on your screen. Starting tomorrow, those experiencing mental distress will be able to dial just 3 numbers to reach the National Suicide Prevention Lifeline. Joining us now to talk about the impact this will have is Dr. Greg Nowalnik, who's in the Hawkeye Nest. Now, I know it's maybe an improvement here, Greg. I don't know. This could be something we have to think about more permanently. Greg is the Clinical Director of Inpatient Services at our Strawberry Hill campus and a psychologist here at the health system. Dr. Nowalnik, what is this new 3-digit number and what's coming up with that? Why now? What's happening? Fill us in.
Okay, so the 3 numbers that you're looking for here are 988, and this number is going to launch, I believe, tomorrow. And it's essentially what it's looking to do. The way that I kind of conceptualize it is this is opening the door to access care just a little bit wider. For some people who are in crisis, it's tough to remember the entire suicide prevention lifeline as it stands currently. So reducing it to 3 digits, easy to track. And it's also, its purpose is also being expanded slightly so that instead of solely for suicide prevention, this is also expanded to now for substance abuse issues, also just general mental health crises. And when you call this line, and also now it's text capable, which is very exciting for, I think, our maybe adolescent aged viewers that might not feel comfortable calling a stranger in their moment, but they might want to send a text. And it kind of allows access to open that door for the conversation.
So people can text with it, they can call it. It's a national number. It's not just here at Kansas City. It's a national number, right?
Well, correct. But interestingly, it initially will try to route you to the local group of clinicians. But if those are all busy, then it's nice that it has the backup of pulling you out to the national line. So ideally, you're going to get a clinician in the state of Kansas who is going to be able to, these are licensed master's level therapists who are specialized in this area of crisis resolution and intervention. So rather than just calling someone who's been trained how to ask certain questions and link you to services, you're actually going to be able to really engage in immediate crisis resolution.
Greg, I remember earlier in the pandemic, we were talking about how the suicide calls or the calls into the suicide prevention line that we used to have had gone up like 100 or 1,000-fold. But the Wall Street Journal has been reporting that 1 in 6 calls to a national suicide prevention lifeline end without ever reaching a counselor. What concern does this bring up, and is this number going to help us solve that?
Oh, I mean, the concern is that if somebody is actually at that point and they're willing to reach out to care, the last thing we want to do is leave them on hold for a long time. So what this has done is expanded the availability and access. Even certain states, including Kansas, the legislation has provided for additional funding for mobile response teams. So that's not every state across the union, but for those of you in Kansas, it's a benefit that you might be able to take advantage of. And essentially, everything has been expanded, and what we're looking at is that this is really a great opportunity to get more people linked to care. So it's a win all around.
You know, Greg, you have previously said on this program, and I really like this turn of phrase, suicidal thoughts are not a personal shortcoming, but a chemical imbalance combined with situational pressures. Talk to us again about that, because I think people feel guilty for feeling bad, but the reality is life is hard.
Life's very hard, especially in the last 2.5 years, really clear evidence of that. But yeah, it's feeling down, feeling blue, feeling like you can't handle it, feeling helpless, hopeless. These are not personal choices. These are not personal shortcomings. Situations can mount up, pressures can mount. And when relationships fall apart, when careers fall apart, these are overwhelming stressors. And when depression and anxiety, which have an adaptive continuum whereby they kind of motivate us to make changes in our lives, when those start to become overwhelming, then you need to be willing and able to reach out for help. And it's not about any sort of additional self-flagellation that's necessary. This is saying, hey, I've got problems, I need help. And there are folks like myself and countless others out there who are willing to answer that call and be there and support you and get you through this and back to your life as you've envisioned it.
You know, people do beat themselves up a lot for all of our own personal feelings. Have things gotten any better since society sort of opened back up? I mean, especially for adolescents, high school kids. What's the story there?
I think that it's a case-by-case situation. For some people, they came out of it and had really maybe even secured and solidified relationships that were already in place. For others, they may have fallen a little bit more behind and lacked some of the contact. So I think that now as we've come back out, what my hope is that people see interpersonal contact, engagement, doing the things that before they might have said, oh, the best plans are canceled plans, that maybe now they recognize, hey, you know what, being able to do stuff is something I took for granted. I'm really happy to be out and engage and live my life to the fullest. So that's the hope. And I think that when things are now getting back to, I mean, I don't want to use air quotes and say normal, but, we're starting to really see, live concerts, all the different events without all the stress and panic, and even people getting COVID who have been vaccinated saying, yeah, like my son had it, and then he got another virus. The other virus beat him up much worse than COVID. So really pleased with that.
All right, Dr. Wollenbach, thank you so much for being here today. Always appreciate you here on the program. The Suicide Hotline National, text or call 988, and hopefully this will be a big step forward in trying to make sure we save more lives.
For sure.
All right, thank you.
Thank you.
Hey, did you know the first proton therapy treatments for cancer were delivered, wait for it, in 1954? I bet the equipment looked a little different back then. Since that time, a lot has indeed changed. 2 months ago, we opened the only proton therapy center in the metro here at the University of Kansas Cancer Center, now a comprehensive cancer center, and not everyone likes going first. But for Lisa Webb, being the first adult patient to receive proton therapy, it was the answer to her prayers. Jessica Lull has her story.
53-year-old wife and mother Lisa Webb knew something wasn't right.
My vision was more like an octagon. I was looking at objects, things, people, and it was just starting to get worse. And so I went to the eye doctor. They had no clue.
An MRI at the University of Kansas Health System revealed a tumor called skull-base meningioma. It was wrapped around the main artery of her brain and left optical nerve. Doctors removed some of the tumor, but not all. They recommended a radiation treatment plan that before now would have required Lisa to travel out of state for weeks away from her family.
We had this technology that was coming on board soon. I thought she would be a great candidate that could have significant advantages in her case.
For Lisa, it was worth the wait. She became the first adult patient to receive proton therapy at the University of Kansas Cancer Center. We spoke with her week 1 of her 5-week treatment.
I'm being positive, and I'm saying my rosary daily, going to Mass still on Sundays with the family, and just being positive.
And we were there just weeks later when she rang the bell. A joyful moment for her and her medical team.
Just, excitement and happy for Miss Webb that we were able to do this here and that she was able to come in, get her treatment, and then go back home and have dinner with her family.
Wow, it's always better to not have to travel hundreds or thousands of miles to get therapy and get it right here at home. So let's turn now to Dr. Ronald Chen, Darren Kistler, and Sarah Solomon. Good morning to all of you. Lisa is the first patient to finish her course of proton therapy. We always talk about proton therapy to treat cancer patients, and Lisa did not technically have cancer per se. How is proton therapy benefiting her condition, and will she need more proton therapy? Ron Chen.
That's a great question. There are certain types of tumors, such as meningioma that Lisa had, that are not technically cancers because they don't have the chance to metastasize elsewhere. But these, what we call benign tumors, can still grow and really cause problems for an individual. So a meningioma in the brain, for example, even if it doesn't metastasize, can grow and really cause neurologic compromise. And for her, it caused trouble with her vision and really can push on nerves, push on the brain, and cause problems. And so in these cases, even though it's not a malignant cancer, benign tumors can still be treated, in her case, with surgery to remove part of it. And proton therapy really will help control that so it will not continue to grow. And I don't think she will need more proton therapy in the future because she's already finished her course of treatment.
How did you identify Lisa? How did you even get to this point?
Well, I think, so what Lisa had is, of course, she developed symptoms with her vision. And of course, when somebody develops trouble seeing, that really alerts you to be able to see the doctor. And with meningioma, usually what happens is you would get a scan, whether it's an MRI or a CT scan, that will see that tumor. Actually, meningiomas have a very clear way of how they are visualized on an MRI and CT scan. So we really knew up front that it was likely to be a benign meningioma, and it was hitting her nerves. And so she had surgery. And then after surgery, because it didn't remove all the meningioma tumor, she needed radiation treatment, and proton was the best type of radiation for her because it would be able to treat that tumor without really impacting the rest of her brain, which is really important. And so, but I think at that point, the discussion was, well, we don't have it here in Kansas City for a few more months, but there are other places that have protons. Are you able to go to Arizona or Texas or Minnesota? Now, because this is a benign tumor, there actually is the opportunity to wait until we were able to offer that to her in May. And so she was, and I think for many patients, traveling out of state for a daily treatment for 5 or 6 weeks is really very difficult, especially when somebody has work every day. You can't just quit your job and move somewhere. So she was able to wait, and we were able to give her the treatment she needed.
Yeah, that is great. So I'm going to ask all three of you to help me answer this question, all right? How did the first 2 months of treating patients been? And has it been all that you've expected, or has it been more? Dr. Chen?
Well, I think it's been going great. What I think is really important is that this is not really new to our team. Proton therapy is not new to our team. The proton therapy machine is new to the metro area and it's new to Kansas City. But we have assembled a team of experts that came from other places that have very deep experience with proton therapy. So we knew what we were doing from day one. We knew what we were doing from day -1, minus a month, minus 3 months. And so we were
minus
able—
3 years, actually.
minus multiple years. We've been preparing for this for a long time, and we really assembled a great team. And so I think that the first 2 months have really gone as expected. We continue to ramp up the number of patients we treat. We're really happy to graduate Lisa and other patients from treatment. I think it's really, and we're really having a large demand of patients really calling, asking about whether proton therapy is right for them. So it's really gone really well from my perspective.
Yeah, that's so Sarah, you're the navigator, right? That means people come to you. You're the first person who these patients contact. Talk to us a little bit about what that's like and how that's helped us here in Proton.
Yeah, as part of being a nurse navigator and then a nurse navigator program, you're that first point of contact for most patients, and you get them established within KU. So that can mean getting them tied in with their oncologist, radiation oncologist, a surgeon, but really in identifying any barriers to care these patients may have so they can get the best care possible in a timely manner. So it's a very comprehensive process, and a lot of patients are grateful for that one point of contact to get them started in this overwhelming journey for their treatment.
Yeah, I know that's got to be such a big deal, and I've sent enough people down to the cancer center, been a patient down there myself, so it's a big deal, and having that nurse navigator, you're so scared, you just don't know what's going to happen, and that's such a great reassuring voice on the line, and somebody's got your back about things. So you get to work with other patients that you are seeing coming through too. What sticks out most in your mind around the proton? Well, how is that different than other areas?
I've seen two really neat things with proton starting at KU, and I think the first one is these patients come, to KU with an interest in proton or the proton treatment, and with navigation and other departments, they've been tied into so many different resources that they didn't know exist, and they really get this comprehensive care when they come to KU, and they're learning about, you know, other treatments they may not have known or clinical trials they haven't known about really in the process. And the second and one of the best parts is how grateful these patients are. And any of these diagnoses are so overwhelming, and to then think that you might have to travel and pack up your life to get that treatment is a huge burden. And to be able to, you know, take that burden off and be treated locally for these families and patients is huge, and they are so grateful for it.
Yeah, I bet they are. So, Darren, there is always a lot of nervous excitement about launching a new service. What have the last 2 months taught you and your team?
You know, I think for me, the very first patient was a child. I think you walked into that room and you saw that patient, and it really validated everything that we've been working on the last, I would say, 5 years about bringing proton therapy to the Kansas City market and to the patients that we serve. So for me, that was really the take-home message. It's all about the patient, and it always has been. So we're really, really proud of that.
Yeah, that's a big deal. So, Darren, I remember those pictures we had when they're bringing the proton thing up the highway, and then the big crane taking it and putting it there. Were you nervous?
Yeah, you know, I was. I mean, it was really a lot of excitement. So, you know, at some part we were pushing to a deadline, you know, over and over and over to make sure we get this service opened and offered to patients. And now that it's here, I would say that my anxiety level has come down just a little bit as we got our team hired, and gosh, as Dr. Chin said, we have got a stellar team that's been pulled together, and you know, we couldn't be more excited for that.
And so, be honest, have you had to ever pinch yourself to just kind of say that, hey, this is actually going, it's not a dream, and we're right here in Kansas City?
Yeah, it's gosh, what a pinnacle. You know, that it's just a special time, as much energy and time as everyone's put around this. And you know, there's so many people to thank. You know, there's certainly the Proton Home team, but you know, we've had a lot of patients receive daily anesthesia care, and so you know, our entire anesthesia care team and all of our nursing team that are doing pre and post recovery of those patients. That you know, it's a great you know, display of teamwork.
Yeah, that is very cool. Okay, Ron Shen, remind us, who are good candidates? What are the patients who are good candidates for proton therapy, and how do you decide?
Yeah. Well, proton therapy is a form of radiation treatment. So radiation is one of the major ways we treat and cure cancer. And proton therapy is a form of radiation that's able to really accurately pinpoint at the tumor and reduce radiation and dose and side effects to the surrounding organs. So in that sense, proton therapy really has a broad spectrum of indications. We can use proton therapy for all sorts of cancers, from prostate to breast to brain tumors to head and neck cancers. We can also use proton therapy for all different ages of patients, from kids to adults. And so really it has a broad indication for different types of cancers and even some benign tumors like we talked about. But I think in terms of patients that we've treated so far, we've treated a number of kids with cancer, and kids really is a high priority for proton therapy, because the important thing is to be able to treat their tumor and leave the organs that are still growing in these kids alone as much as possible from treatment. So they really benefit a lot from proton therapy. We've treated quite a few patients with tumors in the head and neck area where there's a lot of sensitive structures like nerves and brain. But we've also treated prostate and other indications as well. And so it's a broad indication, but it's really easy for a patient to call the navigator line and get them set up for a second opinion or initial consultation to see if proton therapy is the right treatment for them.
Yeah, it is. I mean, you just think about this, and I've known you well enough. You always have a bounce in your step. I think as you guys were starting the first proton patients, I was a little worried you're going to get a concussion because you're going to be bouncing off the ceiling a little bit. All right, let's go to some of the questions from our viewers. For that, we head to Studio B and Alexis Del Cid. Good morning, Alexis.
Good morning. We have some really good questions coming in. The first one is from Luther. Luther wants to know, how did Lisa stay up there on that table so long, and how did her treatments last?
I guess I'll take that.
You bet.
And so proton therapy, again, as a form of radiation treatment, is a daily treatment. So usually it's given Monday through Friday every day. And for different diagnoses, whether it's a brain tumor, meningioma, or breast cancer or prostate cancer, it's 5 days a week for often 4 to 6 weeks often. And in terms of how long it takes on a daily basis, again, depends on the diagnosis, and it can range anywhere from 20 minutes to 40 minutes. Depends on the diagnosis and how complicated the treatment may be for the particular patient. Actually, it's pretty easy to lay on the table. There's really nothing to do. You sort of lay on the table, enjoy the music that's actually playing in the room, and you relax and you sort of watch the machine move. For most patients, there's really no sensation from the machine. So you sort of lay there, listen to the music. Some people take a nap. It's really, for patients, really not a very a big experience, actually.
How long does the therapy actually last? The radiation part, how long is
Yeah,
that?
that's right. So on a daily basis, a patient may be on the table for 20 to 40 minutes, but actually the majority of that time is set up and being as accurate as possible. So when Lisa's on the table, for any patients on the table, we actually take pictures and images to make sure we can line up the tumor precisely. And every day is a little bit different, so it takes actually quite a bit of time to be as precise as possible. And then once the setup is finished, the actual treatment time is often only just a few minutes. So most of the time is actually spent being as accurate and precise in positioning as possible.
Do we have a long waiting list for these patients? Do we have a lot of people lining up?
There actually has been, since we opened the Proton Center about 6-7 weeks ago, there actually has been quite a bit of demand because a lot of patients are wondering, well, is this technology right for me? Is it right for my diagnosis? So actually, I think Sarah has been very busy navigating patients to the right doctor, the right expertise for the consultation as quickly as possible. And we can usually see a patient within a week of them calling, sometimes shorter, to get them the opinion on whether proton therapy is right for them. And actually, if proton therapy is right for them, we can get them the treatment very quickly.
So have you been busy, Sarah, with a lot of phone calls?
It's been a little busy, but
Yeah.
it's a good excitement. And when you work with a great team and they're agile and patients get good care, it's always a good experience.
Nobody's ever accused me of being agile. Alexis, other questions?
I have a COVID question from Jean Beasley Schlotznauer on Facebook. Jean would like to know, per the CDC, a non-symptomatic vaccinated person exposed to COVID doesn't need to quarantine and should wait at least 5 days to test. If that person gets asymptomatic COVID, how are they not spreading it during those first 5 days before testing?
That's a great question. Unfortunately, Doc Hawk is in the house. So, Hawkeye, let's take this one on because the CDC guidelines were written a while back.
Yeah.
And BA5 maybe a little different. Let's take this on.
Yeah. Are you sure you want me? Do you want Nawalnik? Sounded like
I
he
know.
was a shinier model that you liked.
He did have his pocket squared today. He looked special.
He's dapper.
I know, he is dapper.
You know, I think that's a good question. You know, I had to deal with this issue, not me personally, but a friend had texted earlier this week just about that. Somebody in the family was positive, and they were wondering about quarantine isolation. Everybody in the family, in the household, was vaccinated and updated. So, yeah, I mean, I think it's a very difficult question, and that is exactly right. You know, you aren't having to stay home and quarantine while waiting for symptoms. You can still be out doing things. The other thing you can always do now is also continue to wear masks if you are out in public, if you have that concern. And I think that's a very valid concern in thinking about other people. You can wear masks. We know that helps reduce the spread as well until you can get yourself tested. I don't know how much people are actually doing that and testing rather than just waiting and monitoring for symptoms in everyday practice, but that is certainly the current guidelines.
And you may be asymptomatic, so I think that's exactly right. Whichever, if you've been exposed, you're worried, just put your mask on. And it's, you know, we don't wear masks as much as we used to, but the numbers are rising a little bit. Let's talk about our numbers.
Yeah, and I would say also about the masking and everything like that. We know that is the major problem with SARS-CoV-2 as opposed to SARS, where you weren't spreading the disease until after symptoms started. Now you can spread the disease
early on.
1 to 2 to 3 days before, and we know that 30 to 40% of people, especially early on, didn't have any symptoms at all. So that is a very good point. Actually in the hospital we have 23 active patients with 2 in the ICU, none on the ventilator, 12 in that recovery period. I was optimistic and hoping that over the next couple weeks we would see that 23 active number go back down to the teens and even single digits. But as we know, the circulation is very high in the community, and so we have been dealing with high circulation. And I feel that our numbers in the hospital haven't gotten too overwhelming, but we know it's continued to be high. So hopefully we can still see maybe in the next 4 to 8 weeks a decrease.
I sure hope that's right. We're going to say no new variants.
Yeah.
SARS-CoV-2 could just go away, probably not. But it is a bit of a struggle right now because BA.5 is out there. It's circulating widely. And if we can look at the New York Times heat map for just a minute, guys, you have that. There you go. Look at all the orange on there. If you remember a few weeks ago when we were showing this map, it was a very pale light, kind of very light yellowish orange, barely tell. But now it's got a lot more orange in it. And you can see some real hot spots where the really deep colored and the darker colors are. We're being a bit surrounded coming this direction. And that's reflected in the Johnson, Wyandotte County numbers in Kansas and Jackson County, where the transmission per the CDC is now in the high level, Hawkeye. Talk to us a little bit about that.
Yeah, it's true, and we've been monitoring that. You know, they change the masking updates every Thursday, and so last week we looked, the past few weeks we've looked. Now certainly we know that with the number of cases, again, those that are officially diagnosed, but also the people that are testing at home, and the people that maybe not be testing and just believe that they have it, you know, we understand now, and that is why the county or the CDC has made that county recommendation. If you're in indoor spaces, please mask. So it's still out there. I think everybody, and now we're in the summer, so people are traveling as well. You know, you look at Coronavirus Central down there in Florida.
Did you just call Florida Coronavirus Central?
I mean, there's no restrictions.
There are no, I know. And the beaches,
but luckily you can do a lot of things outdoors.
A lot of stuff outside.
Yeah.
I love it.
So I think the main point is, please understand your individual situation, the situation with your family and your bubble, and understand if you are going to be doing those situations, going into restaurants, going to parties, understand that there is probably going to be 1 or 2 people at least at a minimum who have exposure to coronavirus or who could be spreading it. So just take those precautions.
So, you know, there is a lot of code out there right now, and I think we just have to recognize that BA.5 is here. It's more transmissible. Do you think folks are going to be symptomatic? If they're going to get it and be symptomatic with it, I think it happens faster than 5 days. That was the Delta variant that was based on, I think. And this BA.5 goes pretty fast.
Yeah, and so I think what a lot of that is actually our immunity kicking into high gear. What that is when your body sees that virus, now you've had immunity, again, hopefully safest by the vaccine, but also we know that people have been infected, reinfected, and reinfected more. And so what that is that immune response kicking in, and that is why you're having symptoms maybe a couple days earlier than before. So I think that is a good thing. Just some new articles out just looking at that as well. Hopefully, and we believe that the severity is not anymore. Certainly the early data would support the fact that Omicron and its subvariants are maybe less severe than Delta. But again, it's more like that original ancestral strain, which we know could still be severe. However, we have those layered immunity from vaccination and infection in people. Now, certain countries, it's a little bit different. They don't have that because of lack of vaccination or of trying to keep the virus out, which is probably a not sustainable method to use. But overall, we know that you continue to have immunity, you continue to have better protection. Hopefully then, that does mean more protection against hospitalization.
Yeah, and I think across the world, there's not the same sense of masking and isolation because it's been so darn long. You can see that there's concern about Africa, Europe, and other areas where they're experiencing a pretty significant surge. Alexis, I understand we may have another question.
Another COVID question, so we're going to keep Doc Hawk here for this one. Someone wrote to us on one of our, I believe this is from YouTube, question related to COVID. When people get vaccinated repeatedly, is it possible for people to have autoimmune diseases after getting vaccinated over and over again?
We are just not seeing that, Hawkeye.
Yeah, you know, I think that's right, Steve. You know, that is a theoretical issue, and that is a theoretical as you move further forward. But we know that we have gotten repeated vaccines, say for influenza, which people have gotten for decades at a time because they're getting them every year. There's other vaccines that people are getting, such as the Tdap booster, every 10 years. That is a theoretical concern for sure, but we haven't seen it, just to your point.
Yeah, and I think the way we look for that, folks, is that we watch pretty carefully in the database the number of people who have been vaccinated who develop an autoimmune disease versus the people who develop an autoimmune disease. And let's also remember the people who get COVID and develop an autoimmune disease. By far and away, the people who get COVID are the ones who have the biggest challenges. Alexis.
And I was just going to say, and let's continue to remind the public that there continues to be active surveillance for those type of associated problems. So, you know, if it does seem to be a signal in the data, that will be investigated, and we'll certainly let you know.
Yeah, and I don't know that there's any magic about being vaccinated every 6 months versus every 12 months, and you know, we don't see that coming out of influenza. Alexis, another question I hear.
We have a question from the Kansas City Star. This is from reporter Natalie Wallington, who would like to know about the different variants. So she writes, I'm wondering whether the hospital system or other officials are tracking the spread of BA 2.75 and whether we believe it has reached the Kansas City area yet. Is there any information available about how this strain might behave differently from previous ones, including BA5?
All right, BA5, BA2.75, lots of points out there, huh?
Yeah, there's lots of points, and we've been dealing with these variants really since the later part or the middle part of 2020 with the variants. Now we have Omicron and its subvariants. That was a variant, the B.2.75, I believe, was a variant originally identified in India. It looks like it's taking hold some places. Unfortunately, we've talked about this too, Steve, that we just don't have the resources or the, I guess, most efficient reporting of sequences. So we don't have any of this sequence data. I get all my sequence data from either the CDC or covariance.org, but again, that is quite incomplete compared to some other countries here in the United States. So I don't know that we have a large proportion of that in the United States. I'm sure it is here, but the overwhelming majority, especially based on the forecast, is that really the BA5 is the variant of dominance right now. But overall, I think what we've seen is that clinically, these viruses really are no different from one another. These variants are no different. Yes, Delta may have had a higher chance of severe disease, but everything else really seems to be under that umbrella of quite similar. And so I think that is one of the other reasons that we need to continue to promote and endorse the vaccinations, because the vaccines continue to work against reducing your risk of hospitalization and severe disease.
Yeah, I think great point. And we both watched the wastewater testing, so and that's kind of where it predicts a 1 or 2 weeks in front of these major surges. I haven't seen the BA2.75.
And that may actually be more up to date, like you said, maybe not for actual true infection of people going to the hospital, but early surveillance for that.
Yeah, advertisement. If we want to know and be more in front of this kind of stuff, we got to improve our public health infrastructure, because that's the key link to try and get to that, Alexis. Any other questions right now before we go back? All right. So we are talking about the Proton Therapy Center here at the University of Kansas Cancer Center and its 2-month anniversary. Joining us this morning, Dr. Ronald Chen, the chair of our Department of Radiation Oncology, Darren Kistler, Senior Director of Radiation Services at the University of Kansas Cancer Center, and the guy who was most nervous as the proton beam was being dropped into its tomb there, and Sarah Solomon, our proton nurse navigator, who said she was nervous when she got to the studio this morning. But Sarah, dude, you are like really good here. You can come back. I don't know about these other guys.
Oh, thank you.
We will continue in our discussion in a minute, but doctor, we want to take a look for just a moment for this.
So the most uncomfortable part is just being have to stay there still. The beam feels like nothing, except when they do the beam on my brain, I get a weird smell. And that's the only really effect that you'll know. That's the only reason I know it's happening at all.
What does it smell like?
It's kind of like burning, but not really. It's such a unique smell, I can't really describe it.
All right. Dr. Chen, burning. That doesn't feel good. So tell me, that's not. Does everybody have that?
No. So first of all, that's really great information from the patient's experience. When we treat the brain with whatever treatment we give, sometimes you have your brain operated on. Sometimes you use radiation to treat part of the brain. That part of the brain that's being treated may be the part that's responsible for smell. And when you move that part of the brain, the nerves a little bit, it can trigger a sensation of smell, or maybe it's a part that relates to vision. You can see a vision of light. And so when we're treating the brain with whether surgery or protons or radiation, sometimes some of those neurologic sensations can happen. And so it's different for everybody. But proton therapy, as the patients, as Alex said, really the beam itself has no sensation, and when we treat other parts of the brain that's not related to the nerves, really there's no feeling whatsoever, no smell and no vision or no light.
Yeah, it's a big deal. So, Sarah, when people call you, are they scared?
They are. They're scared, but they're excited. Everybody has fear and anxiety starting, I think, a new treatment or wanting to get started in a treatment and worried about that timeline and availability. So it's talking them through that process and like I said, getting through those barriers to care and getting them in with the right doctor, the right disease-specific group, and getting that ball rolling for them as quickly as possible.
And do you get to talk to them as they're getting their therapy or after their therapy? Do you get to keep having the conversations with the patients?
I do, and that's my favorite part of the whole process is getting to still have that one-on-one experience with that patient and that emotional day of ringing the bell and having that final thing and seeing all the support these patients have behind them is my favorite part of the process.
And do you get to be there for the bell ring?
I do get to be there for the bell ring.
I think that would be so cool.
Lots of tears.
Please, tears, yes.
I just want to chime in about the navigation aspect that what Sarah is doing. I mean, a patient who has a new diagnosis of cancer, you're thinking that you've seen a doctor, you've heard a recommendation, well, am I going to get a second opinion? It's so much work, what do I do? We've built the program so that all you have to do is call the navigation line, and the navigators like Sarah will walk you through the entire process. You call them, you want a second opinion, they'll get you an appointment, she will get all of your records, she'll find the right doctor to talk with you for a consultation. She will go through the entire process with you. Really, I think what Sarah has said in sharing her experience is really actually the true patient experience. I think it's really important for patients to understand that.
Yeah, that is really a big deal. So Darren, in 2 months, what has stuck out most in your mind about the proton beam?
You know, today we've treated 17 different patients. I think yesterday we hit our 300th patient treatment. And it's been really the number of patients under the age of 25 that we've provided care to. I think it's around 40% of the patients. And so here again, I think that's a unique patient population. When we think about cancer, typically we think about an older adult population getting cancer. And so, you know, proton therapy is really serving a much younger audience.
Yeah, that's a big deal about the ability to take care of young people, because you don't want to because generalized radiation, Dr. Chen, can cause a lot of other kind of side effects to other tissues. Proton being very narrow, I think especially for a child, that would be a big deal.
It is a big deal. Many of the pediatric cancers are actually highly curable. We can cure pediatric cancers often with a very high percentage. But now I think with cancer care, it's not just about getting to the cure, it's about their quality of life. It's about the rest of their life and how they're going to do. And so for a child, for example, if we're treating a brain tumor, we want to leave the rest of the brain as free as possible so we don't affect their IQ and ability to function in the long term. If we're treating the other parts of the body, we want to leave these other organs as freely as possible so we don't damage the other organs as the child is growing. And sometimes having unnecessary radiation to other parts of the body can also cause another cancer as the child grows into the future. So really, I think proton therapy is really hugely important for children. It's also really important for adults. We treat a lot of adults with proton therapy too, especially for tumors that are very surrounded by other organs that are very sensitive. And so we do treat both kids and adults with proton therapy.
Yeah, that's a big thing. All right, Alexis, I bet there's some questions out there from our viewers.
We do. We have another round of questions. For Dr. Chen, one of our Facebook friends writes, is it effective to use proton therapy to treat children with DIPG, I might be butchering the name of this, diffuse intrinsic pontine glioma? Why or why not? Is proton therapy expensive? Thank you.
Well, that's something who's got some medical thing going on there. That's a big deal.
That's great. So DIPG is a type of brain tumor for kids, and I do think, not knowing this particular kid's diagnosis, I do think that that's a worthwhile diagnosis for us to really get a consultation related to proton therapy. So I would encourage this patient to call the navigator line. Really, I think that's important for us to see. A kid with a brain tumor, I think it's worthwhile for us to think about, look at the records and see if proton therapy is right. What was the second question?
I think it was
is it expensive?
Is it expensive?
So is it expensive? That's a very good question. proton therapy is covered by insurance because it is a standard treatment for cancer. And so when the patient comes in and if the doctor says, look, proton therapy is the right treatment for you, insurance should be able to cover that. And so if insurance covers the treatment, then really the cost of the patient should be relatively low.
It is. So, Darren, talk to us for just a real quick second. What is the average cost of a proton beam therapy?
You know, so the treatments are based upon how many treatments or how many fractions the patients get. I mean, the technology is much larger. There's less of them, so the cost of the technology is more, and so that does factor into the cost of the treatment. As far as how much more it is than traditional radiation oncology, you know, a lot of cutting edge technology in oncology is expensive. And you think about immunotherapy drugs and so there's, you know, it is the latest and the best technology out there for many of these patients. So, but it is more expensive than traditional photon-based radiation, but so is the cost to bring it to the Kansas City region.
The cost of this is so much higher. It's not even comparable. The machinery, the vault, everything you have to do for proton is much more expensive than standard radiation therapy.
Well, I think the other thing that I would say related to cost is that it's just not related to the cost of treatment, but actually related to the overall cost of taking care of a particular patient. If we have a technology that the treatment itself costs a little bit more, but if it reduces side effects for many years downstream and we eliminate the side effects treatment that may be required for a patient, hospitalization, surgeries, and medication, actually that balances out. And sometimes for many indications, proton therapy actually may be overall cheaper for the patient.
Now there's a cost of therapy and then there's a toll of the therapy. Okay, Alexis, another question.
Allison has another question about proton therapy, and then I'm still getting questions about COVID here. But Allison wants to know, how does the success rate of proton therapy stack up to traditional radiation?
Yes, very good question. So in terms of curing cancer, so radiation is a primary treatment to cure many types of cancer from head to toe: brain, head and neck, lung, breast, colon, rectal. Really, radiation is used to treat many and cure many kinds of cancer. And proton therapy, in terms of the cure rate, compared to traditional radiation, the cure rate is the same. That actually is not the benefit of protons. It cures just as regular radiation. The benefit of protons is be able to cure the cancer while minimizing radiation to other organs and reducing side effects. And in that sense, that's really the big advantage of proton therapy.
And prostate cancer?
Proton therapy actually has been used very commonly for prostate cancer. It's probably one of the most common conditions treated with proton therapy.
Alexis.
Wow, the viewers are really, they really have a lot of more questions about proton therapy. I do want to get to this quick one from Isaac about COVID because it's so hot. Everybody's been cooling off at pools and lakes, and Isaac wants to know, what's your take, I'm paraphrasing, what's your take on the safety of going to public pools right now?
Yeah. You know, I think it's outside. And plus, there's a whole humidity thing in the air that causes all sorts of funny air currents out there. I think you're probably mostly okay.
Yeah, no, I would agree. Steve, we've always been a proponent of being outdoors, whether it's walking around Loose Park in the earlier part of the pandemic, still now. There was some journal articles that looked at maybe it's still easier to spread outside than it was. I really think there's not a lot of support for that. I think you're still going to be safer, just like you said, humidity, turbulent air, things like that. I think you'll be safe going there. You're going to be more at risk of getting a sunburn, so obviously wear your sunscreen.
Excellent advice, especially from an ID doctor. Well done.
My dermatology colleagues, they'd appreciate it.
They like you. All right.
And from our fair-skinned doctor, Dr. Hawkins.
Yeah, there's a couple of us on that category.
I do have some more questions about proton therapy. Shirley wants some clarification. Can proton therapy be an alternative for chemotherapy for some kinds of cancer?
All right.
So that's a great question. Again, not knowing the specifics of a particular patient, the general answer is they're very different treatments. So proton therapy or any form of radiation is a very targeted treatment. When we target the beam at a particular tumor, that's really the only part of the body that will be treated. Chemotherapy is very different. Chemotherapy, you get that infused, or maybe you take it as a drug. It goes over your entire body and treats your entire body. So the way they're used is different. Sometimes the patients need both, but really one is not used to replace the other because they're very different mechanisms.
Alexis.
Got another question from Susan. Susan, again, and people are so curious about this. It's such a fascinating treatment. Susan wants to know what specific kinds of cancers are treated by proton therapy. Once again, the specific cancers she wants clarity on.
Yeah.
Dr. Chen, we may just have to have you take root here.
Happy to do it. Happy to come back tomorrow. I know it's a Saturday, but we'll have an extra show.
Okay,
if
we're in
we
the
need
studio.
to.
The guys are always working.
Yeah. But any type of cancer or any type of tumor, for that matter, where radiation is indicated, proton can be used for. So radiation is indicated for many different types of brain tumors, head neck cancer, lung cancer, breast cancer, gynecologic cancers, prostate cancer, rectal cancer. That is all the types of cancers that radiation can be used for. And whenever radiation can be used, proton could be a possible alternative. And so it really has a wide indication. And also we treat kids all the way to adults with conditions.
Alexis.
Dr. Chen might need to camp out on our Facebook page and
I
keep
guess
answering
so.
these
we'll
questions.
Keep it going. Yeah.
I have one other question that just came in. Let me pull up her name. Ruth would like an update on the long haul COVID topic. And specifically, she wants to know how some of our previous guests are doing. I mean, I know the two women that I've interviewed and done stories on are doing a little bit better, but they still have long haul syndrome and POTS, which we've talked about. Do the doctors on the set, do you guys have any updates on how our long haul patients are doing?
Okay, I don't have a long haul update on specific patients, and we really have to talk to those patients about giving out their specific information. But what we do know is that we still are seeing long haul patients develop with all the different variants. It doesn't go away just because it's BA.5 instead of Delta.
Yeah, exactly. There has been talk of maybe there's some reduction with certain variants, but also we have these layers of this immunity now from vaccination and previous infections. So we know that long haul is going to be a massive problem moving forward as far as hospital capacity, people's daily living. We know that the government is putting forth a lot of resources to help study that, to make it better. We had our virtual long haul clinic here at the health system. There was such an overwhelming demand, we had to stop that. That doesn't mean that we aren't seeing them. Our providers are absolutely seeing long haul patients. It's just not in an expedited form, but if you are having certain symptoms, we get you to the right specialist to do that. I don't know exactly how everybody's doing. Hopefully a lot of those symptoms are going to be going away after about 6 months, but we know that they can continue even past that, especially for those things like POTS, and we're learning more about treatment, both symptomatically and techniques that you can do to improve that. So just a lot of information about that, a lot of questions that are still being asked, and a lot of answers that we still need to get to.
All right, Alexis, final question.
I have two more questions.
Okay,
they're
there
both
we go.
good ones, and then we'll have to cut it off. Kathy would like to know if chemo has stopped working, is proton therapy able to help? I have an older relative with prostate cancer.
Okay, can you substitute?
I think it's I think that let's say for a patient with prostate cancer, they've had chemotherapy, and maybe even after chemotherapy, they still have the progression of cancer. There could actually be some indications for radiation therapy or proton therapy. I think it depends on the exact situation, but we actually do often use radiation therapy for that situation for patients.
We need to know a lot more from that question, especially chemotherapy is not real common for prostate cancer.
It happens for patients often when they have metastatic disease.
Yeah. Yep. Alexis.
Angela has one more question. Angela would like to know if there is any treatment available for scar tissue damage to the throat after radiation to the throat.
That's a hard one.
That is a tough question. Radiation treatment for some patients can cause scar tissue after the patient is cured in that area. For some patients, not everybody, there could be scar tissue that forms. And I think oftentimes there are studies to show different things, that medications or other treatments that can potentially reduce the scar tissue. I don't think there's great treatment to completely eliminate it, but actually some of the faculty in our Department of Radiation Oncology actually have an interest and expertise in that area, and we'll be happy to talk to this patient some more. We have faculty who have expertise in this.
And Sarah Solomon would be an excellent navigator to reach out to.
I would love to help them.
All right. We're going to get to final thoughts, but I have one last question for Dr. Chen. Is Proton Beam the same beam that Scotty uses to get you back on the Enterprise?
What show is that?
Oh, jeez. Fine. You'll get a final thought now. Darren Kistler.
Yeah, so for me, proton therapy, it's a difference between care and caring. And so proton therapy allows us to provide that care. But gosh, you know, just spend a little time in our department, you see the compassion that the clinical team is demonstrating to the patients. I mean, I see our therapists and our nurses, you know, and our child life social work team. Gosh, it's just that compassion, and that caring is something that really goes a long way for the cure of these patients.
Sarah.
I'm just grateful for the support of KU and for these patients that trust us with their care and come back every day. I love them.
Yeah, that's awesome. All right, Dr. Chen.
Well, I think we've talked a lot about proton therapy and the technology. That's only one piece of cancer care. It's great to have great technology, but the team that you have, the expertise of the team, I just want to emphasize in my final thought. We have recruited doctors with proton experience from all over the country, trained at Harvard, Johns Hopkins, MD Anderson. So this is not new to us. We have proton therapy doctors that have had years of experience with protons on our team, so we know how to best use it. We have recruited physicists from all over the country who have proton experience. We have dosimetrists and therapists who have proton experience. So we have assembled a proton expert team to know how to use the technology, and the two are really important together to be able to offer the best outcome for the patient.
Dr. Hawk?
You know, I would agree with Dr. Chen, one of his comments earlier, even a benign tumor you don't want. But luckily, we have our comprehensive cancer center. And most importantly, it's the people that are helping to get you through this time and get your family through this time. So, you know, if you have questions, obviously, Dr. Chen's been answering them, but just great people working here and obviously great resources.
Dr. Chen, one last question for you. There was a recent study by the National Institute of Health that says a Mediterranean diet can help in treating and preventing certain types of cancer. Can you explain why what we eat can also help us and which cancers are impacted the most?
Yeah, that's a great question. And I actually have a personal interest in this question because when I saw my primary care doctor a few years ago, I was recommended to take the Mediterranean diet. She actually gave me a pamphlet, and so I actually read about it. So that kind of a diet, of course, is high in fruits and vegetables, high in fish, olive oil, a little bit of alcohol, but really very little red meat. And I think that kind of diet has been studied by many, many studies to have a lot of good health effects, cardiovascular disease, but particularly in cancer, there is actually an increasing number of studies to show that Mediterranean diet actually can reduce and actually prevent certain types of cancer. For example, there was a recent study in prostate cancer where men who are on active surveillance with early prostate cancer, Mediterranean diet may actually be able to potentially slow down the progression on active surveillance in prostate cancer. There was another study that showed that Mediterranean diet may be able to reduce breast cancer incidence. And so there's more and more cancers and more studies to show that actually this can have a potential positive effect.
And you know what? It also tastes good, as I do the Mediterranean diet, and I think it's awesome. So the reason I asked that is because we are starting a new segment here on the Morning Medical Update. You will see some Fridays called Foodie Fridays. I love being a foodie. The first one is going to be focusing on the Mediterranean diet and eat healthy. We want you to have a great weekend. And here's my final thought for the day. We're watching the map get a little more orange, kind of like that bright orange tie that I have on today. But the reality is, remember that the rules of infection, prevention, and control, they travel with you. They keep you safe wherever you go, even with the Delta or the Omicron BA.5 variant, the BA.2.75 variant, and all the other BA variants in between. We want to really thank our Proton Beam Therapy team here today. All of these guys do awesome work, the whole team, the Comprehensive Cancer Center thing. This is a really amazing time to be a patient here at the University of Kansas Health System. Hey, we thank you all. You guys all have a great and safe weekend out there. We'll see you back on Monday at 8 a.m. And remember, until then, live long and prosper. We'll see you on Monday.
Hello, everyone. Thank you for joining us today. Today, we're going to be making a chicken and feta salad stuffed pita. We'll be starting off with some frozen diced chicken. A little bit easier to use the already frozen cooked product. The idea behind this recipe is making it fast and quick in your kitchen at home. We use a frozen, pre-packed sorted peas, a little bit of diced tomato, a little bit of feta cheese, some diced green onion. Today we're using a low-fat Greek yogurt. Greek yogurt's got a little bit extra protein in it, a little bit of probiotics, makes it a little bit healthier for the gut. And a little bit of dill for that seasoning. Now we're going to mix all this together. And what we do is we take a full pita round, slice it in half, slice it open, stuff it with your favorite greens. Today we're using a Tuscan mix. When that's all said and done, you get a nice little mixed product. Here is our finished product, our pitas stuffed with our chicken and feta salad, fresh greens. Happy, healthy eating.
More than 300,000 kids 5 and under have now had their first COVID shot. I'm Jessica Lovell. Monday at 8. That's not the only shot kids need. Why doctors' offices will be busy next month. We'll see you at 8 on these social media channels.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.